Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everyone to week 5 of Basic Dermatology curriculum organized by Saudi Society of Dermatology and Dermatological Surgery. My name is Leen Alturki and I will be the session moderator today, inshallah. Firstly, I would like to welcome you all and thank you for joining us. This session is being recorded and it will be made publicly available along with the course content on a society official platforms on a social media after the course completion. Today's session plan will include the main lecture delivered by Dr. Abdulhadi. Please feel free to type your question in the chat at any time and we will address all the questions during Q&A segments at the end of the session. So our session today will be delivered by Dr. Abdulhadi Jfri. He has a double board certified from USA and Canada and a Harvard Complex Derm Fellow. Thank you very much, Dr. Abdulhadi, for joining us today. It's our pleasure and honor to have you with us.
Thank you so much for having me. I'm not sure if the screen is clear to everyone.
Yes, it's clear, Doctor.
Okay, perfect. So usually during the derm review courses, I go over dermatology, dermatoses in pregnancy in one slide, like a summary table, which I actually put at the end of the presentation. But since there is a dedicated talk for this, I will just go over a couple of high-yield important things for the exam and review also important points in this chapter. I don't have any conflict of interest, and the objective is to discuss, normal physiological changes in the skin that happens during pregnancy, and then the pregnancy-related dermatoses, which are 4 diseases. I need you to know the high yield about each one of them because they usually come on the exam. Definitely, you can't go to a dermatology board exam without at least one question on pregnancy dermatoses. So what are the normal changes? They usually, in pregnancy, hyperpigmentation in most ethnicities, especially our Middle Eastern and Southeast Asians. The darker, the more or the higher risk of hyperpigmentations. It can be in the axilla, genitalia, around the nipple. We have this black line in the abdomen that called linea nigra. The mask of pregnancy or melasma is also tend to get darker during pregnancy. They can have hyperpigmentations anywhere. Even their own freckles or nevi, they can get darker during pregnancy. And sometimes they can increase in size, but that's due to the proportional increase in the breast, preparing the mom for the breastfeeding after pregnancy, or the abdomen because of the distension of the abdomen. Now, during her pregnancy, a lot of ladies, they take vitamins. And I think a lot of them, they believe that the vitamins they've received during pregnancy helped a lot with the hair. But in fact, what happens during hair, most of the phases, we have 3 phases for the hair: anagen, telogen, catagen. So most of the hair goes to the anagen phase. That's why the hair during pregnancy is usually perfect. It's thicker, it's longer, and when she delivers, everything goes back to normal. And add to that the risk of telogen effluvium from the physiological stress, the mental stress from delivery. That starts 3 months after delivery, which usually, again, they relate that to breastfeeding, and it's not true. But this is important to understand that hair is usually good during pregnancy and it gets worse after pregnancy, the hair fall, and that's due to the telogen effluvium / hair is going back to normal phases. There is no specific changes in the nail, except if she has already a longitudinal nevi, it can get a little bit darker, melanonychia. Other than that, there is no specific nail changes. Now, what about sweating? Sweating increases all over except in palms and soles. They can become more sweaty on the back. That will lead them to miliaria. And we have a couple of subtypes like miliaria rubra, for example. The sebaceous gland activity is variable. Some pregnant ladies experience breakout of their acne, while the others, they don't have really that bad breakout. Also rosacea. So rosacea and acne, variables. Maybe in a pregnancy they can get better, maybe they can get worse. But other diseases, like, for example, atopic dermatitis, gets worse in pregnancy because it's a Th2. And there is during pregnancy a Th2 predominance over Th1 to protect the baby. So psoriasis usually during pregnancy gets better and goes into remission, except, of course, pustular psoriasis that also flare up with hypocalcemia in addition to pregnancy. But in general, atopic dermatitis is worse during pregnancy and psoriasis is better. If the patient asks you what's going to happen with my acne rosacea, we don't know. It can get better or it can get worse. The other diseases that also tend to improve during pregnancy is hidradenitis suppurativa HS and the Fox4 dyes. Some ladies, they say if I'm pregnant with a boy, I will have really bad acne. Very good skin because the boy is leaving my beauty. But if I'm carrying a girl, the girl will take all my beauty and my skin will look terrible. This is one of the rumors that you may hear in the clinic, but it's not true. Now let's talk about also the distension in the abdomen can lead to the stria gravidarum, which is a big issue, to be honest with you, that we also see with stretch marks. We can see them with over distension of the abdomen, sudden weight loss, sudden weight gain. Based on network meta-analysis and the largest studies, they found that moisturizing during pregnancy with thick moisturizer that contains, for example, shea butter, or Centella asiatica. For example, serums that contain Centella asiatica, any cream that has the word Cica, Cica Plus, Cica Flate, Cica whatever, contains Centella asiatica. So it's an anti-inflammatory and repairing cream that can help with the stretch marks and also reduce their appearance if she would moisturize all over the pregnancy. But once it happens, it will go through the phases from being red to white. And later on, when it's white, we treat them as we treat scars. So we do microneedling radiofrequency, collagen biostimulators in the clinic, and at-home vitamin A derivatives applications or vitamin C, collagen boosting ingredients. Those have evidence. But again, you have to be realistic with the patient and set up expectations by letting them know that this is a scar. It's not going to go away. We're just trying to make the skin look better. And of course, the skin tag as well can happen with weight gain, insulin resistance, especially if she gets like, high glucose during her pregnancy. That can also increase the risk of skin tags. Vascular changes, the angiomas common, telangiectasia, non-pitting edema, of course, the varicosity with hemorrhoids because of the increased intra-abdominal pressure, the pulmonary erythema, one of the differential diagnoses other than liver diseases, pregnancy as well. Also gingival hyperplasia that can come also in dermatology. We have to know the differential diagnosis, calcium channel blockers, other infections can lead to gingival hyperplasia, but pregnancy is one of them. And then pyogenic granuloma as well, because it's another vascular thing. It's very common in pregnancy. I have seen so many pregnant ladies when they get like a trauma or pick at one of the pimples and they develop pyogenic granuloma. Okay, so I prepared 4 cases where we can go over the case, and then at the end, we'll discuss every thing. So again, here are the 4 diseases that I want you to know. Pemphigoid gastrocnemius, polymorphic eruption of pregnancy, intrahepatic cholestasis of pregnancy, and atopic eruption of pregnancy. So this patient is at the end of her pregnancy. Everything happens at the end of the pregnancy except one disease, which is atopic eruption of pregnancy happens at the beginning. And why? First trimester, because of the switch in the Th1 predominance to Th2 predominance. That usually starts in the stretch marks here, this disease. It's very pruritic, urticarial lesions, papule, erythematous papules, no previous medical history, nothing on exam. So our differential diagnosis, of course, because it starts in the stretch marks, it's in the abdomen, it's at the end of the pregnancy, it can be polymorphic eruption of pregnancy. Of course, atopic is yes, but that's usually early on in the pregnancy. It can be flare-up of her underlying atopic dermatitis or a new onset. Pemphigoid gastrocnemius usually spares the stretch marks and it's around it. We can see blisters as well. It's like bullous pemphigoid clinically. Drug eruption also is a possibility. Urticaria in general, or viral exanthem. So what do we need to know for the exam about polymorphic eruption of pregnancy. Number one, we have to know that it starts at the end of the pregnancy. Almost like an allergic reaction to the breakdown in the collagen. And when it happens once, usually it doesn't happen again. It's safe for the mom, safe for the pregnancy, safe for the baby. Nothing will happen. It happens once and that's it. And you forget about it. It's not going to happen in the upcoming pregnancies. Just the things that you should look for in the stem to get the diagnosis. Look for third trimester, appears within the stretch marks, the abdominal stria. So that's a clue. And then sparing what? Sparing palms, sparing soles, and around the umbilicus, the periumbilical area. Lesions are polymorphic. That's why it's called polymorphic eruption of pregnancy. And it has no harm on the mom or the baby. How do we treat it? Uh, it will resolve spontaneously, but sometimes it's itchy, so we give topical steroids. It's usually safe in pregnancy. We also give antihistamines such as loratadine or cetirizine. Both are safe in pregnancy. And if it is severe, then we can give a short course of steroids. The biopsy is non-specific and DIF will be definitely negative. This is our second case. So this patient, again, is in the third trimester. These lesions are very itchy, urticarial with some blisters, and these blisters are tense. So we need to do a biopsy and DIF, of course, because it's a blistering dermatosis to rule out pemphigoid gestationis. This is an exam favorite disease because there are so many things to ask about. Number one is they can ask about if the mom is at risk of anything, and the answer is yes. She is at risk of increased possibility of developing Graves' disease. The second question is they can ask about what finding you will find on the DIF. It is exactly similar to bullous pemphigoid. So IgG antibodies against the NC16A segment of bullous pemphigoid antigen 2. What else can we ask? We can get asked about in the exam. Of course, remember that neonatal lupus, few percentage of them, due to the antibodies can have transient antibodies from the mom to the baby, can have annular lesions that usually stays for around 3 months. It's exactly similar to here, where 10% of the children, the newborn, can have transient blisters and usually resolve spontaneously. Things to remember for this disease, it can happen within or around the umbilicus, while polymorphic eruption, usually within the stretch marks, and it spares the periumbilical area. Lesions here add to it the blisters. That's important. And then the harm on the baby. So is there any risk of on the baby? Yes, they can have small for gestational age or reduced the birth weight. These are the two impacts on the baby, in addition to the transient blisterings. For the mom, it's Graves' disease. And then the DIF is similar to bullous pemphigoid, where we have linear C3 and the basement membrane and IgG as well. So the baby premature, small for gestational age, and then the transient blisters as well in 10% of the babies. How do we manage it? Of course, we need to give topical steroids, potent antihistamines. Oftentimes in these patients, we require to give systemic steroids that we taper, and it's usually safe. If it is really severe, we can do plasmapheresis like exchange. But in general, we do steroids. This is the third case. So this patient again presented in the early on in pregnancy, and she presented with purpuric eruptions on the abdomen extremities with no previous history of atopy. So probably atopic eruption of pregnancy. This is the only disease that happened first in the pregnancy, the first trimester, while the other three diseases usually happen at the end of the pregnancy, third trimester. This disease is due to the switch that happens in the immune system of the mom to protect the baby by switching from Th1 to become predominantly Th2. And Th2 is two letters, so atopic dermatitis. Th1 is one letter, psoriasis. So remember, psoriasis will go into remission, two letters Th2, atopic dermatitis will go into flare. It can be, again, a new onset or a flare-up of her previous eczema. So the question comes is how we treat it. So We have to treat it with topical steroids. A lot of mom are afraid of using topical steroids during pregnancy, but we can reassure them if they did not exceed 500 grams in like 2 weeks. And even if they did that, the only harmful effect on the baby will be small for gestational age from systemic absorption. But other than that, it does not have a big harm on the baby. So I don't think we need to take a biopsy, but in general, it will cause spongiosis, which is an edema that we see in the epidermis. And then sometimes we can see increased IgE on the labs. Of course, we have to do the general skincare measures, moisturizer, topical urea or topical corticosteroids, oral antihistamines. We can do a narrowband UVB, it's safe in mom and pregnant ladies. And then we can also do topical antibiotics if it is superimposed with bacterial infection, uh, i.e., eczema, for example, impetiginized eczema. Okay, so this is the fourth and the last case. At 24 weeks pregnant, presented with pruritic lesions of the hand, nothing to see on the exam, and her bile acid level was elevated, ordered and elevated. What should you expect? Of course, this is the most dangerous one among the four, which is the intrahepatic cholestasis of the pregnancy. What we see is excoriated lesions mostly. We don't see primary lesions. Intrahepatic cholestasis of the pregnancy because it can lead to stillbirth, so the baby can actually die, and we need to treat that with ursodeoxycholic acid in pregnancy to prevent the fetal impairment from the uric acid. What happens is probably from the pressure there is a reduced bile secretion and excretion actually from the abdominal increase in the abdomen and also the pressure on the gallbladder. It can lead to this fetal anoxia and also impaired myocardial function. There is a predisposing factor, which is a mutation in ABCB4 that was in the literature, I think, over the last few years as a publication. But in general, I don't think they will ask you about it in the exam unless they're very up to date. But in general, remember the important things, which is the stillbirth, harmful risk on the baby. There are other contributing factors that can also increase the risk, such as if there is a superinfection with viral hepatitis C, selenium deficiency, and increased intestinal permeability, which is also known as leaky gut. So typically, they become with very generalized pruritus, mostly on thumbs and soles with no primary lesions. And again, they can have jaundice in 10%, it persists even after delivery, and usually recurrence happen with subsequent pregnancy in 45 to 70% of the patients. And even with OCPs, it can happen. By the way, even bullous pemphigoid, the autoimmune one, it can happen with menstrual cycle, it can happen with OCPs, it can happen with subsequent pregnancies. We'll see that in the table. So as we mentioned, this is the most dangerous one. The bile acid usually is elevated more than 11. The risk on the baby will be premature labor, intrapartum fetal distress, and also stillbirth. Maternal risk, vitamin K deficiency, steatorrhea, gallstones. The treatment is ursodeoxycholic acid. It's off-label, and we usually give 50 milligram per kg per day or 1 gram once a day. And again, it can actually continue after delivery. If there is a signs of vitamin K deficiency, we give intramuscular vitamin K. Okay, let's go over this table summary. I think this is the most important slide of the presentation that you should review before the exam. Pemphigoid gastrocnemius. We mentioned that can start within the umbilicus or around the umbilical areas. It's similar to bullous pemphigoid. It's autoimmune, and we mentioned everything happens in the third trimester except atopic in the first trimester. Here in the pemphigoid gastrocnemius, we set the picture on the IF is similar to bullous pemphigoid, linear C3 and 30% IgG. It will happen almost 100% in subsequent pregnancy and with OCPs. How do I remember it for the exam? I remember PG. So G is for Graves' disease. So the mom is at risk of Graves' disease. PG is premature, for example. So this is prematurity. And G, gestational age. So small for gestational age. And then you remember that 10% of these kids will have transient lesions. Then polymorphic eruption of the pregnancy. Anything that increases the size of the abdomen, if she has polyhydramnios, if she has multiple gestations, like, if she's pregnant with twins or triplets, then also that will increase the size of the abdomen and will increase the risk of this collagen breakdown that will lead to polymorphic eruption of pregnancy. Nothing risk for the mom or the baby. It happens once, it doesn't happen again. Bye. Intrahepatic is the most serious one. No patients, itchy, mostly palms and soles. This is the most dangerous one. In fact, it can lead to prematurity, fetal distress, and also stillbirth. Treatment is ursodeoxycholic acid. Atopic eruption is the only one that happens in the first trimester, and that's due to the switch in the Th1 to Th2. And we said that two letters is atopic dermatitis, so patients will itch. They may have increased IgE, and it can be a new onset of eczema or flare up of their previous eczema. And I think that's pretty much it. It's a very quick, small presentation. Let me know if you guys have any questions about pregnancy dermatoses.